Oncology and hematology. Blood transfusion. Blood transfusion is commonly done in the emergency department. It might be because of hemorrhagic shock, or it might be because of severe anemia and the patient is symptomatic and you want to do a blood transfusion. So, what are the prerequisites to do a blood transfusion? Mainly the monitoring, what we are seeing in this slide. The pre-transfusion. Before you start transfusion, you need to check for the vital parameters that include the heart rate, blood pressure, temperature, respiratory rate. These vital parameters should be checked within 60 minutes before you start the transfusion. It is not that you are checked 2 hours before you start the transfusion, 3 hours before. No, that is not accepted. Ideally, just before you start the transfusion, you need to record the vital parameters. While transfusing, you need to record again this vital parameter, that is heart rate, blood pressure, temperature, and respiratory rate every 15 minutes or after each unit you start, then give a gap of 15 minutes, then record the vital parameters. Once you have finished the post transfusion, that means you're done with the transfusion, then within 60 minutes of stoppage of the transfusion, you need to check the vital parameters. Throughout the time of transfusion, you need to make sure that patient is visible, should be in your sight. Should you can monitor the patient and visualize if something drastically go wrong, you can intervene immediately. Transfusion reactions. Transfusion reactions I have divided according to the symptoms. It might be an high grade temperature, a febrile reaction might be, or it might be because of an allergic reaction, or it might be because of an difficulty in breathing. So various presentations they can come up with. What will be the differential diagnosis? Whenever they come up with an fever, a febrile reaction, we can broadly classify as mild fever or moderate and severe fever. Mild fever. Whenever it is a mild fever, that is the temperature being equal to or more than 38 degrees Celsius or 1 to 2 degrees above the pre-transfusion baseline. So it is not always hard and fast rule that the temperature will be around 38 degrees Celsius and less than 39. It might be sometimes 39.1 to, yes, it can be seen. Mild fever is most of the time seen in a delayed extravascular hemolytic reaction. So it is not inside your muscles, it's not inside the veins and the arteries, it's outside the veins and the arteries. That's why it is known as extravascular. So where exactly it is happening? The hemolysis is happening in spleen and liver. They do not present immediately. It takes days together to present to the emergency department. So the history will be like the patient had a transfusion yesterday and today he has presented with an temperature of so and so. So that kind of history will be there. So this management is entirely asymptomatic. Sometimes they may not even present to the emergency department. Whenever the temperature is on the higher side means the temperature equal to or more than 39 degrees Celsius or more than 2 degrees Celsius above the pre-transfusion baseline, then we have two main differential diagnoses. Either it might be an bacterial contamination of the blood products. So once it is bacterial contaminated, you are infusing the bacteria inside. So what will happen? It will result in severe infection and it can go into shock. So it will present like an septic shock, which is rapidly developing. So fever with chills, tachycardia, and shock. That is bacterial contamination. What is happening? What do you do? Stop the transfusion immediately. Take the blood cultures, start them on IV fluids, start them on broad spectrum IV antibiotics, and return the implicated units to the transfusion lab for the cultures. So the 4 steps what I have mentioned is nothing but the sepsis 6 what I'm mentioning here. So you're treating like in sepsis here, what we have learned already. The only additional is the units of the transfusion, what are they? You need to send it for the cultures and you need to stop the transfusion because you do not want to insert more and more bacteria into the circulation. Next one, the differential diagnosis is ABO incompatibility blood. So whenever you give someone who is A positive and you ended up giving a B positive, so intravascular hemolysis will occur. The RBCs will start breaking down. The antibodies of the host will start breaking down the RBCs which you are infusing. So this results in an acute intravascular hemolytic reaction. This is life-threatening. So they present with fever and chills, mainly because of breaking of the RBCs, fever and chills. Pain at the site of transfusion. This important point, pain at the site of transfusion. Lower back pain, flushing, shortness of breath can be there. Dyspnea, additional important. Hemoglobinuria, additional important. Tachycardia and shock. So some features overlap. For example, fever, chills, tachycardia, and shock can be seen in bacterial contamination, can be seen in acute intravascular hemolysis. What helps to differentiate? Pain at the site of transfusion, shortness of breath, hemoglobinuria. These are not seen in bacterial contamination. If these are present, then you're strongly suspecting an ABO incompatibility, also known as acute intravascular hemolytic reaction. So what do you need to do? First, you need to stop this transfusion immediately. IV hydration to maintain the diuresis. So make sure enough fluids has been given. Diuretics might be required after giving enough fluids. You might be giving furosemide. Cardiovascular support as indicated. Remaining units to be returned to the lab for further compatibility testing to see is there any mishap is there any clerical mistake is present. To see those things, you need to send back the units what you are having to the lab. So what is basically what you need to remember? It's just a symptomatic treatment. There is nothing specific treatment is there. It's just the symptomatic treatment. Stop the infusion, return back the units what you are having, the blood units what you're spending. Any blood investigations will be helpful here. Yes, definitely the blood investigations will be helpful here. Direct anticoagulation test will be positive in ABO incompatibility. Repeat the ABO compatibility test. It will show incompatibility. Urine dipstick, if you do, it shows hemoglobinuria. This all three are positive in ABO incompatibility. It will not, or it will be negative in bacterial contamination. That blood investigations also will help you to differentiate between ABO incompatibility and bacterial contamination. Allergic reactions. Allergic reactions, mild allergic reactions usually presents with what? A rash and some itching associated with it. So you treat it with an antihistamine like diphenhydramine. Wait till the symptoms resolve. Once the symptoms resolve, you can start the transfusion. So the first step is to stop the transfusion. So whenever there is an allergic reaction, stop the transfusion. If it's a mild, they are just presented with an rash and an itching associated with the rash. Just give an antihistamine, treat it symptomatically, then later on you can start the transfusion. No, they're having severe symptoms. They're having a rash, they're having itching, along with it, more than two systems are involved. For example, they are having breathing difficulty, there is an hypotension. So in this patient, it is a full-blown severe allergic reaction known as anaphylaxis. So you're treating like any anaphylactic reaction. So stop the transfusion first, then start treating like any anaphylaxis by giving adrenaline IM 0.5 mg. Here, you're not allowed to start the transfusion at all. Here, you can start the transfusion once the symptoms have resolved. Breathing difficulty. Breathing difficulty, it can be an ABO incompatibility, which we already studied, and there I stress that dyspnea can be one of the symptoms the patient might be presenting with. Fluid overload stage. Fluid overload stage is known as transfusion-associated circulatory overload. So a patient who is a CHF, okay, a patient who is an CKD, these patients are at risk of developing fluid overload. So when you give an blood transfusion or platelet transfusion or FFP unit, so what basically you're giving? You're giving a fluid. So increase in intravascular volume can result in fluid overload stage. X-ray, if you get it done, it shows an pulmonary edema picture. BNP, if you get it done, it will be on the higher side. The symptoms usually develops within 12 hours of starting the transfusion. Evidence of volume overload like typical pulmonary edema like dyspnea, edema, tachycardia, hypertension can be present. Treated like any other pulmonary edema like an heart failure, what we are studying in cardiology by giving diuretics. Furosemide will be the preferred drug here. Transfusion-related acute lung injury. If you get an X-ray done, it might appear like in pulmonary edema or it might appear like an ARDS. Bilateral infiltrates can be seen. BNP will be normal because this is not a fluid overload state this patient is in. So it appears like pulmonary edema, but it is not an pulmonary edema. It more looks like an ARDS. Why does it happen? We do not know. What is the underlying cause? We do not know. But it is very much similar to that of the ARDS, and the treatment is also very much similar to that ARDS. Intubate and start them on mechanical or support them with a mechanical ventilator. Usually, it is kind of a transit phenomenon. If you can support them for a 3 days duration, that is 96 hours, 3 to 4 days duration, they recover completely by themselves. Coming to the acute intravascular hemolytic reaction, here BNP will be normal, chest X-ray usually will be normal, or sometimes there might be a bilateral infiltrates might be present in this individual. So what will help you? Chest X-ray and BNP will help you to differentiate between all these three diagnoses what I mentioned here. Transfusion-associated graft versus host disease. It is a rare thing to encounter, but whenever you encounter the fatality rate it is quite fatal. Most of them die because of this. So what are the risk group people? There are four risk group people what you need to be aware of. The fetus which is receiving an intrauterine transfusion, congenital immune deficiency disorders, Hodgkin's lymphoma, or allogenic stem cell transplant recipients. In these four individuals, what you need to do? You need to make sure the blood products what you're giving, it is irradiated. This is important. You're making sure the blood products is irradiated. Okay, once the symptoms develop, it is very difficult for you to control. Once the reaction comes, it is almost most of the time it is fatal. It is a delayed transfusion reaction. It takes days together to present, but once they present, you will not be able to save them. So you need to make sure the who are at risk. Once they are at risk, treat them with irradiated blood products. That will help you to prevent the transfusion associated graft versus host disease. So prevention is important here rather than the cure. They basically present with multi-organ failure after few days. That's all you need to remember. So it is highly fatal. So what you need to do, you need to prevent. So find out or make sure whenever you come across an risk group, you give blood products which are irradiated. Post-transfusion purpura. So whenever you give an platelet-rich antibodies to a foreign in a recipient with a prior sensitization is present to a foreign platelet antigen. So basically what happens here? So the antibodies have been developed because the patient is already been sensitized, and whenever you do an platelet transfusion, so it just starts destroying the platelets. It just doesn't destroy the recipient's platelets. It also destroys the donor platelets. Both what the patient has his own platelets as well as the external platelets what you are giving. It destroys both the platelets. So usually they present after days together after a transfusion, and bleeding and disseminated purpura is commonly seen. In this patient, how do you treat it? So purpuric rash, this is the purpuric rash what I'm talking about. You're treating with high doses of intravenous immunoglobulins. Reporting transfusion. So all we have learned about the transfusion reactions, various transfusion reactions we have learned about. How about the reporting per se? You are expected to report all the blood transfusions reactions except the mild febrile and allergic reactions, except this two. Rest everything should be reported to MHRA short and serious adverse reaction and events. So you need to report them. All these three entities needs to be reported. Remember, mild febrile reactions and allergic reactions. Mild febrile reactions is extravascular hemolytic reaction, and allergic reactions, you need not report it. Rest everything needs to be reported. Additionally, it is mandatory to report to the NHS blood and transplant. It is mandatory if the patient develops an transfusion-related acute lung injury or there is a bacterial contamination, then additionally you need to report to NHS blood and transplant. This is important. What you need to remember, whom to report once a patient develops a transfusion reaction. We do not usually report to mild febrile and allergic reactions. All the type of transfusion reactions are immune mediated except one, that is the fluid overload. It is the fluid overload what is happening, that is the non-immune mediated. Rest everything is immune mediated. The most common transfusion reaction is febrile non-hemolytic reaction. Okay, febrile non-hemolytic reaction, it's an they don't hemolysis doesn't occur here. It's just a fever what they present with. This is known as febrile non-hemolytic reaction. It is a very mild version of it. Usually we treat it with paracetamol. Nothing needs to be done. This is the most commonest transfusion reaction what you come across. When do we call it as a massive transfusion? By definition, we call it as a massive transfusion if you're transfused more than 10 units over 24 hours, or you're transfused 4 units in an hour's time. If any one of this criteria is satisfied, then you call it as a massive transfusion reaction. What will happen? whenever they whenever you do a massive transfusion, this known whenever the criteria is satisfied, then you call it as a massive transfusion. When you're doing a massive transfusion, there will be relative thrombocytopenia and relative depletion of coagulation factors. So because of this, there will be increased risk of bleeding. That's why it is recommended always give platelets and FFP also when you're doing a massive transfusion. Blood is stored in a citrate medium. Because it is stored in a citrate medium, citrate toxicity can occur, resulting in an hypocalcemia. So what is the most commonest transfusion reaction what you see in most commonest complication you see because of a massive transfusion? It is the hypocalcemia. Remember this, it is the hypocalcemia which is very commonly seen. Sometimes there might be increase in potassium levels because these are stored, so cells can break down releasing potassium. Blood products are usually stored at a lower temperature, that is around 2 to 6 degrees Celsius. So can result in hypothermia if you are not used blood warmers. So it is recommended that when you are doing a transfusion, especially massive transfusion, always use blood warmers. Look out for hypocalcemia, it can occur. Look out for hyperkalemia, which can occur in these patients. They can go into clotting factor and platelet depletion. Make sure you give additional platelets and FFPs. Also, just do not keep on transfusing PRBs. Now we are seeing the pathway, clotting factor pathway. What we are seeing here, there are two pathways. One is intrinsic pathway, extrinsic pathway. These both end up in a pathway known as common pathway. This is highly simplified pathway. What is required from the exam point of view and clinical point of view has been put across. I'm not going in detail of this pathway. Warfarin. There are direct oral anticoagulants. There is fraction and fraction heparin, low molecular weight heparin, dabigatran, fondaparinux. I'll be discussing where this drugs acts on and how they have the anticoagulant activity and what are the drugs which kind of an antidote for these drugs. Okay, so remember, both via an extrinsic and intrinsic pathway, whichever is activated, they eventually activate the factor 10 into an activated factor 10. This activated factor 10 converts prothrombin into thrombin, that is nothing but factor 2. This factor 2 converts the fibrinogen into the fibrin, forming the clot. So eventually the clot is formed. Where does the warfarin act on? Warfarin mainly acts on extrinsic pathway. Okay, remember, warfarin mainly acts on extrinsic pathway. It prevents the synthesis of the clotting factors which are involved in the extrinsic pathway. These clotting factors are 2, 7, 9, and 10. They are dependent on vitamin K. So it basically acts on the vitamin K and prevents synthesis of the clotting factors which are dependent on the vitamin K. What is the antidote whenever there is a warfarin overdose? You want to reverse the warfarin effect. Then you can give prothrombin complex known as PCC. Next one, what you are seeing here is direct oral anticoagulants. Anything which ends with Zaban, Rivaroxaban, Apixaban, Edoxaban, these are all known as direct oral anticoagulants. Where does they act on? They directly inhibits factor 10A. Is there an antidote for the same? Yes, for the reversal, adenosine alpha, what you'll be using. Next one, what we'll be seeing is heparin, unfractioned heparin. Unfractioned heparin activates the antithrombin 3 and it directly inactivates the factor 10A. That's the mechanism. So the similar mechanism you will be seeing in low molecular weight heparin and similar mechanism you will be seeing in fondaparinux also. There is minute differences which are present there, which are not important from exam point or the clinical point of view. What you need to understand is all these three drugs, that is unfractioned heparin, low molecular weight heparin, and fondaparinux, activates antithrombin 3. In turn, what it does, it reactivates factor 10A. So what are the antidotes? What you can use it? For unfractioned heparin, it's the protamine sulfate, what you can use it. For low molecular weight heparin and fondaparinux, you can use adenosine alpha. Adenosine alpha, you can use it as an antidote. Where does the dabigatran act on? Dabigatran directly acts on factor 2, which is also known as thrombin, and it inhibits directly. The antidote for dabigatran is idarucimab. So let us see each one of this. Before seeing, to monitor the clotting factors, if APTT is prolonged, what are we really thinking about? If APTT is prolonged, we are mainly thinking about intrinsic pathway. If PT or the INR is prolonged, we are thinking of an extrinsic pathway. So in extrinsic pathway, PT/INR will be elevated. So what prolongs the PT interval? What prolongs the PT? Prolonged PT is seen in warfarin or vitamin K deficiency, DSC, that is the disseminated intravascular coagulopathy, and liver diseases. Both of this acts on both the pathways, intrinsic as well as the extrinsic pathway. That's why both PT and APTT will be prolonged. Heparin and hemophilia is basically APTT will be prolonged. Now we'll be discussing about warfarin reversal. As I told you, the drug of choice will be prothrombin complex concentrate. Having said that, what is prothrombin complex concentrate? It has the clotting factor 2, 7, 9, and 10. Exactly the same clotting factor which are depleted in warfarin. So you're directly giving the warfarin, you're directly giving the clotting factors. So it will rapidly reverse it. That is the advantage of giving an PCC. So whenever there is a major bleed, the first drug what you will be giving is a PCC. If this is not mentioned in the options, then you will be choosing an FFP because FFP has all the clotting factors. So you're giving all the clotting factors, it will have 2, 7, 9, and 10 also. That's the advantage of giving FFP if PCC is not available. If PCC is available, that will be the drug of choice. Second thing you'll be doing is give vitamin K IV and stop warfarin. So, what are the classical examples of major bleed? The classical examples of major bleed is gastrointestinal bleed and intracranial hemorrhages. So, any IC, any IC bleed or any GI bleed consider as a major bleed. When do we call it as a minor bleed? Any nose bleed or any gum bleed. So, any epistaxis you are having, okay, or any gum bleeds are present. So, these conditions you will be considering it as a minor bleed. If there is a minor bleeding and if the INR is above 5, then you just stop the warfarin and give IV vitamin K. Doesn't matter above 5, whatever the INR range is. There is no bleeding. You just got the blood INR levels as a routine. If it is less than 5, do not do anything. If it is between 5 and 8, stop the warfarin till it becomes back to the therapeutic range. If it is more than 8, that's when you stop the warfarin and give oral vitamin K. There is no bleeding. That's why you are just giving oral vitamin K. Remember that vitamin K. Remember that vitamin K is also known as phytominidin. They are means one and the same. Do not get confused in the exam. PCC stands for prothrombin complex. They can just mention as prothrombin concentrate. The exact long form is prothrombin concentrate complex. They might just give prothrombin concentrate or prothrombin complex. They all mean one and the same. Do not get confused in the exam. Unfractioned heparin. Unfractioned heparin, as I told you, it activates antithrombin 3. Along with it, it also deactivates various other clotting factors also which are involved in the intrinsic pathway. Sorry, intrinsic pathway, not extrinsic, intrinsic pathway. It is given intravenous form. The advantage of it is it has a very rapid onset. The disadvantage is it's very short-lived. So you need to give multiple doses and it is available only in the IV form. So in the IV form, you need to give multiple doses. So you need to monitor this very closely because of the rapid onset and short half-life. You need to monitor APTT very closely. And it is very safe to give you in any renal diseases. Antidote for heparin is protamine sulfate. Low molecular weight heparin. Low molecular weight heparin as well as fondaparinux both and the antithrombin 3 complex. But the additional activity that low molecular weight heparin has is it inhibits selectively the activated factor 10 and factor 2, but it has very minimal effect on it. The advantage here is it has a long life if you compare to the heparin, and the response is quite predictable. So it does not require an continuous APTT monitoring. Because it has a longer half-life, single dose can be given, and it can be given subcutaneously. So the advantage of this is can be given subcutaneously. A single dose can be given, doesn't require any monitoring. That's why if you want to discharge the patient, usually you discharge the patient on a low molecular weight heparin. In the emergency department, you want a drug to start, and it has to start showing its effect rapidly. That means rapid onset should be present. Then you go ahead and select an unfractionated heparin. Fondaparinux. Fondaparinux is basically inhibits the factor 10A, activated factor 10A. Directly it inhibits. So for fondaparinux, is there any antidote? Yes. For direct oral anticoagulant, there are rivaroxaban, apixaban, low molecular weight heparin. All of these three, the antidotes are adiponectin alpha. First two, that is fondaparinux and direct oral anticoagulants. Second line of antidotes will be PCC, whereas low molecular weight heparin, second line of antidotes will be protamine sulfate to reverse it. Unfractioned heparin, protamine sulfate, dabigatran, idarucimab. Remember, multiple times tested in the exam. If that is not effective, then you can give prothrombin complex concentrate. If that is not effective, dialysis will be required. Thrombolytic agents like alteplase, tenecteplase, if it is given within 24 hours, you can give them cryoprecipitate as a first line, and the second line you can give tranexamic acid. Is there any role of activated charcoal? Absolutely yes. If the patient is presented with a direct oral anticoagulants and the dose what he has taken is less than 6 hours ago, So less than 6 hours ago, he has taken a rivaroxaban. So can I give activated charcoal? Yes, absolutely, you can give the activated charcoal. Dabigatran, if it is taken less than 2 hours ago, then you can give activated charcoal. In this both conditions, activated charcoal can be given. In rest of the conditions, activated charcoal is not preferred. Thromboelastogram. Thromboelastogram is kind of an replacement or kind of an alternative to coagulation profile. So usually we get an coagulation profile, which contains PT, APTT, INR, and sometimes it might be having other values also. But it takes time. At least it takes 45 minutes for you to have the results. Whereas the thromboelastogram, immediately you get the report. It's like an ABG machine where you just insert the blood sample and you get the report. So the advantage here is you get the report immediately. That's the advantage of having a thromboelastogram. But the disadvantages are it is tricky to interpret. It is yet to be proven clinically that it is more effective than an coagulation profile what you are getting it done. Why it is tricky to interpret we'll be seeing here. The line what you are seeing here, this is the speed of formation. So how much speed you need to be you need to be visually picking it up. So it is the speed of formation is this line what you're seeing here from here to here. From here to here, what you are having is the speed of clot formation. From here to here, what you are having is the speed of thrombolysis. Okay, this is the strength of clot. Sorry, this is the strength of clot. This is the speed of thrombolysis is from here to here is the speed of thrombolysis. So it becomes very difficult to pick it up. As I told you, clinically it is difficult to interpret. But having said that, it is being used in few of the trauma centers in the NHS. They might start using it in all the centers in the future and might not. It depends on how is the how are the results and what is the feedback given by these trauma centers where they have been using thromboelastogram. So they can ask you about thromboelastogram in the exam. Be aware of it. So this is basically the speed of clot formation, the measure of speed of clot formation. This is basically the strength of the clot form. This is basically the speed of thrombolysis. These three parameters you need to be aware of. Blood products. The three kind of blood products. So blood, the whole blood sample what you're taking. Okay, once you take a blood sample, it can be again divided into three parameters. One which contains RBCs. These are known as packed red blood cells. One which contains platelets. Okay, next one is the FFP. FFP contains the clotting factors. That is the main thing. It contains all the clotting factors. Along with the clotting factors, it also contains fibrinogen. Remember that fibrinogen and the clotting factors both are present in FFP. So when you give an FFP, we usually give 4 to 6 units of an FFP. Just one pack of FFP will not be helpful. 4 to 6 units of FFP we will be giving. Cryoprecipitate. Cryoprecipitate is a derivative from a fresh frozen plasma from FFP. What does it contain? It contains fibrinogen. Okay, so you give 5 units per pool. So when we say that give cryoprecipitate, you are giving 5 units of cryoprecipitate. What is prothrombin complex? This is also a derivative of an FFP. It contains specifically 2, 7, 9, and 10 clotting factors. These are vitamin K dependent clotting factors. This is helpful to reverse the warfarin effect. That's why prothrombin complex concentrate, known as Octa Plus, commonly available in the emergency department in the NHS. You will be giving this to reverse the warfarin. So you should be knowing this. What is packed red blood cells, what are platelets, what are FFPs, what is cryoprecipitate, and what is prothrombin complex. Having said that, few more things you need to be aware of. Which is the best one to give? In a major hemorrhage protocol, someone is acutely bleeding, hemorrhagic shock, trauma is present, whole blood is preferred to be given. But it is not available usually in the blood bank because the half-life of the, or you cannot store it for a long time, the whole blood. They collect the whole blood, they divide it into PRBCs, platelets, and FFPs, then they store it. Sometimes they may store it as cryoprecipitate also in few of the blood banks. Now what we are discussing is the major hemorrhage protocol. It is very important, multiple times tested in the exam, you need to be aware of. Whenever there is a significant bleed is present, okay, or you're suspecting a significant bleed, basically we're talking about the patient going into the shock, or the patient is already in the shock and we are suspecting it is because of the blood loss, then you immediately start on the major hemorrhage protocol. In the major hemorrhage protocol, once you start it, two things you're doing it. You call the blood bank and say activate the major hemorrhage protocol. Then you make sure you get 2 large IV bore cannulas so that you can give the blood products at a rapid pace. You send for full blood count, blood grouping, cross matching, coagulation profile with fibrinogen levels to the lab. So collect the blood samples, get 2 large IV bore cannulas. In the meantime, start giving tranexamic acid. In a trauma, we have already learned we are giving 1 gram bolus followed by 1 gram infusion if they are presented within 3 hours of the incident. Another new protocol is just straightforward give 2 grams tranexamic acid bolus itself if they are presented within 3 hours according to the 11th edition of ATLS. If there is a postpartum hemorrhage, 1 gram you can give bolus. What about in GI bleed? In GI bleed, it is not recommended. It is not helpful at all. So in GI bleeds, do not give tranexamic acid. It is not helpful. Then what you do? Then usually what the blood bank does is immediately they'll dispatch the O negative blood. Okay, so immediately you will be having an O negative blood available. Along with it, they will be giving you the FFPs and platelets, some of the blood banks. So this kind of products will be given to you till they do an blood grouping and cross matching, which takes approximately 25 minutes. In the meanwhile, they'll be sending you O negative blood, FFP, and platelets. So start transfusing this products what you are having if the patient is gone into the shock. That means the systolic blood pressure is less than 90. Then use this blood products. Whenever there is an hemorrhagic shock, there is loss of blood. So replace the blood and blood products. That is the best way to treat the patient, not by giving crystalloid fluids. Crystalloid fluids is just to bridge the gap till you have the blood products available. Once the blood products are available, you are using the blood products. So first you will be starting if it is a medical case. Okay, for example, it is an upper GI bleed the patient is having. Then give PRBCs to FFP in the ratio of 6:4. No, it is an some other trauma cause you are having. It's not a medical, it's a trauma what you are having. Then you are giving PRBC, FFP to platelets in the ratio of 1:1:1. Okay, remember if it's a medical scenario, then give 6:4, that is PRBC 6 units to 4 units of FFP. If it is an trauma case, then you are giving PRBC, FFP, platelets in the ratio of 1:1:1. You are given, still the blood reports are not available, then continue in the same manner what I have discussed. Once the blood products are available, if the hemoglobin is falling and there is active bleed, give more PRBCs. If the INR is on the higher side, then give FFP because it requires clotting factors. If the fibrinogen levels are less than 1.5, then you are giving cryoprecipitate, which helps to increase the fibrinogen levels. If cryoprecipitate is not given in the options, then you can give FFP because FFP has fibrinogen in it. If the platelets are less than 50,000, then you are giving platelet transfusion. You continue doing this till the bleeding stops and the goals are achieved. These are the goals what I'm talking about. There shouldn't be falling hemoglobin. INR should be less than 1.5. Fibrinogen levels should be more than 1.5. Platelet should be more than 50,000. All this goals should be achieved and the bleeding should be stopped for you to just deactivate the major hemorrhage protocol. Otherwise, you are giving in a cyclical manner till you achieve your goals and the bleeding stops. Von Willebrand factor is one of the commonest hereditary coagulation disorders you will come across. This disease has a deficiency of factor 8, which is involved in the intrinsic pathway. That's why APTT will be prolonged. Along with it, there will be decrease in von Willebrand factor, which will required for the platelet aggregation or basically requires for the platelets. So that's why the bleeding time will be prolonged. So remember, bleeding time depends on the platelet aggregation and platelet basically stops the initial bleeding. Clot formation requires clotting factors. So bleeding time prolonged is basically platelets. Clotting time, they're asking about the thinking about the clotting factors. Here, APTT is prolonged because of the deficiency of factor 8. Here, bleeding time is prolonged because of the deficiency of von Willebrand factor. In mild cases, you treat it with desmopressin. In severe cases, cryoprecipitate or you can give factor 8 concentrates. Factor 8 concentrates are readily available in most of the departments. You can give factor 8 concentrates. Factor 5 deficiency will cause prolongation of both PT and APTT. In hemophilia A, factor 8 deficiency will be there. In hemophilia B, factor 9 deficiency will be there. Out of this, which one is more common? Hemophilia A is much more commoner compared to that of the hemophilia B. Hemophilia A is an X-linked recessive disorder which causes a prolonged APTT. In mild cases, you can give desmopressin. Mild cases. In all of these three conditions, what you will be doing? Which factor is deficient? Replace that factor. That will be the best way to treat this patient if they are coming with a major bleed. For example, here there is a factor 5 deficiency. Replace with factor 5. Here, there is factor 8 deficiency. Replace with factor 8. Here, factor 9. You just replace what factor deficiency is there. What clotting factor is deficient, just replace it with that. Idiopathic thrombocytopenia. Idiopathic thrombocytopenia can be broadly divided into primary and secondary. In primary, we do not know the underlying cause. It is idiopathic. That's why it is known as idiopathic thrombocytopenic purpura. In secondary, it might be an autoimmune disorder which is causing it, or it might be an infection. More commonly, it's a viral infection. How do they present to the emergency department? Most of the time, they present with a viral infection and started having bleeding. Like, for example, they're having a gum bleeding, gingival bleeding, they're having a nose bleed, epistaxis they might be having. They might be having a petechial rash. Petechial rashes are the dots what you're seeing here, red colored dots what you're seeing. These are commonly seen because of the platelet deficiency rather than the clotting factors. This is known as petechiae. So whenever there is a petechial rashes are present, suspect that platelet deficiency is there in these patients. So anyone who presents with life-threatening bleeding, platelet transfusion is required. If the platelet count is less than 20,000, prophylactic platelet transfusion can be given. No, the platelet count is more than 20,000, they do not have a life-threatening bleeding, then you can treat it with steroids and IV immunoglobulins after taking advice from the hematologist. Leukemia. Leukemia is a cancer of WBCs. Okay. Two kinds of leukemias are there, acute leukemia and chronic leukemia. How do you differentiate between an acute and chronic? By looking at the blast cells. These are immature cells. If it is acute, there will be large amount of immature cells. So the blast cells will be more than 20%. If it is a chronic, then the immature cells will be less. So the blast cells will be less than 20%. Again, it is subclassified into AML and ALL. ALL stands for acute lymphoid leukemia. AML stands for acute myeloid leukemia. Here, lymphocytes are on the higher side. Here, neutrophils, eosinophils, and the basophils are on the higher side because of the leukemia what they are having. So, ALL is commonly seen in pediatric age group. They commonly present with anemia and spontaneous bleeding. So, important factor what you need to remember is if the blood cell counts are on the higher side, and it is seen in the pediatric age group, then it is an ALL for you. If the blood cells are on the higher side and it is seen somewhere in the middle age, or someone is like an adolescent, for example, 20 years old, you're talking about 30 years old, you're talking about, think of an AML. Along with it, anywhere, if they are mentioned and or rods, think of an AML. Coming to the blood cells which are less than 20%, then it is chronic myeloid leukemia or chronic lymphoid leukemia. Chronic lymphoid leukemia is commonly seen in an elderly person, like above 70 years. And usually they'll be having splenomegaly and lymphadenopathies will be present here. CML, for that matter, is usually seen in middle-aged persons, like in 40s and 50s, what you'll be coming across. Very rarely seen in the children's, and it is associated with Philadelphia chromosomes. Can present with splenomegaly and low platelet counts. So that's how you'll be differentiating. Whenever the first differentiating factor is the blast cells. Next differentiating factor is depending on the age and special things what you'll be looking for. Or rods for AML, Philadelphia chromosome for CML, CLL, lymphadenopathy and splenomegaly. And usually CLL we do not treat. For all the leukemias, what is the treatment? It's none of our business. We usually refer to the hematologist. Hematologist is the one who will be treating these patients. There's another terminology what you need to be aware of is myelofibrosis. What happens? Your bone marrow gets replaced with fibrous tissue. So fibrous tissue, it gets replaced. All kinds of cells will get decreased. That's why it is known as pancytopenia. So there will be decreased RBCs, decreased WBCs, and there will be decreased platelets. That's why it is known as pancytopenia, what the patient presents with. Hodgkin's lymphoma. Hodgkin's lymphoma, usually they present with lymphadenopathies. Okay, various cervical lymphadenopathy, it can be, so various swellings, it might be lymphadenopathy in the groin region, but it always will be asymmetrical lymphadenopathy. What do I mean by asymmetrical? That means the size on the left side might not be similar to the size on the right side. They are all asymmetrical. Cervical lymphadenopathy on the left side will be not similar to the on the right side. So they will be asymmetrical and they will be painless. And it becomes painful usually when they consume alcohol. After they consume alcohol, they complain of the pain. They present with other B symptoms. It is known as fever, night sweats, weight loss can be present. Histopathologically, a key cell what they look for is known as Reed-Sternberg cells. Multiple myeloma, the key signs and symptoms can be remembered with a mnemonic known as CRAP, where C stands for high calcium levels, R stands for renal failure, A stands for anemia, and B stands for bone lesions. Because of bone lesions, they will be having quite a bit of bone pain. So in the bones, they will be having quite a bit of pain and they'll be always complaining about the pains. The diagnosis is done by monoclonal proteins in the serum and the urine. Classically, Benz-Jones proteins is associated with high levels of Benz-Jones proteins is classically associated with multiple myelomas, but it can be seen in other conditions also. It is not very specific for multiple myeloma. Sickle cell anemia, it is important. Usually they present to the emergency department with a complication of an sickle cell anemia rather than an initial diagnosis of an sickle cell anemia. It is an autosomal recessive condition. If one gene is abnormal, how many or what percentage of the RBCs will be abnormal? Or what percentage of the hemoglobin will be abnormal? Around 40%. If both genes are abnormal, around 80% of the RBCs will be abnormal. So what happens? What is the abnormality here? They become sickle. Okay, they become sickle. Once they become sickle shaped, this shaped once they become, the flexibility is lost. They cannot enter into the small vessels. They get stuck into the small vessels. Usually the RBCs will be in this manner and they're quite flexible. They can stretch in this manner and pass through the small arterioles and venules. But once they sickle, they cannot go. Why do they sickle? They get sickle whenever they're exposed to an acidotic medium or whenever there is an deoxygenation or deoxygenated. In these conditions, they get sickled. Because of this sickling, the life of the RBCs reduces drastically. Usually it is 120 days. It has reduced to 10 to 20 days here. So it drastically reduces the drastically reduces the life of the RBCs, which is usually 120 days, has come down to only 1/10 of it, that's 10 to 20 days. If it gets occluded in small venules and arteries, especially of the hands and foot, results in vaso-occlusive crisis. The complaints of severe pain in their hands and in their toes. They can present with an hematological crisis, like an splenic sequestration, where most of the RBCs are kind of squeezed into the spleen, resulting in spleen enlargement, and the hemoglobin drastically falls down. This is known as splenic sequestration. Or they can present with an aplastic crisis, which you learned in the dermatology chapter. Whenever a sickle cell disease person gets infected with an paro B19 virus, they can have bone marrow suppression resulting in aplastic crisis. Pancytopenia is seen in these individuals. Infective crisis. Why infections are prone? Or infective crisis means they are exposed to the infections. What kind of infections? Capsulated organisms they are exposed to because the spleen undergoes autosplenectomy. This non-flexible RBCs, the sickled RBCs get stuck into the spleen, resulting in infarction of the spleen. Okay, eventually that part of the spleen dies because of the infarctions, and they might not be functional in spleen at all by the time they reach the adulthood, resulting in exposure to the capsulated organisms like in strep pneumonia, Klebsiella pneumoniae, Pseudomonas aeruginosus. All of these are capsulated organisms. They get exposed to these organisms. Acute chest syndrome. Whenever a patient presents with an chest symptoms and he is a known case of sickle cell disease, it is an acute chest syndrome until and unless proven otherwise. Acute splenic sequestration, I already told you, they present with severe anemia. Most of the RBCs get stuck into the spleen, resulting in splenomegaly. They get trapped into the spleen. Osteomyelitis can happen, but the most common organism in a sickle cell disease causing an osteomyelitis is Salmonella. What are the investigations you are getting it done? You're getting it done blood film to see the sickling of the disease. And rest of the investigation, like full blood count to see the hemoglobin levels and the RBC count, what do you need to look for? Acidotic medium is present or not, which is predisposing to the acute crisis what the patient is having. This can get stuck anywhere, can result in MI, can result in just infections, can have an infarctions in the brain resulting in an stroke, so CT head will be required. Same thing holds good. Infarction in the liver also can happen. That's why we are getting all these investigations done. The mainstay of the management whenever they present with a, for example, vaso-occlusive crisis, acute chest syndrome, or an splenic sequestration syndrome, pain management is important. They have brought out and they are given and circular here. This basically to stress the point or stress that pain management is very important in sickle cell disease crisis, or whenever they present to the MS department with a complication, pain management is important. So you manage it like a severe pain, not like any other pain. You manage it like a severe pain. Holds good to the NICE guidelines, where you need to give the painkiller or you need to assess it within 15 minutes of the arrival and give a painkiller within 15 minutes. Then assess for the effectiveness within 15 minutes. Okay. Usually they'll have an written protocol what needs to be done if they present within complications. You can follow the you can just follow the protocol what's been mentioned. What is the treatment? Oxygen. Because one of the causes for the sickling of the RBCs is low oxygen levels. So you give a supplement the oxygen. What if the oxygen saturations are above 94%? Still we give oxygen or not? It is controversial. Few literature says still go ahead and give oxygen. Few literature says do not give oxygen because it will not help you at all in those circumstances. If the patient is dehydrated, cannot take orally, then intravenous fluids might be required. As I told you, pain management is important. They'll be having severe pain, opiates will be required. In certain conditions, the hemoglobin might have drastically fallen down, like splenic sequestration syndrome, where blood transfusion will be required. These persons are predisposed to capsulated organism infections. So give empirical antibiotics in all the patients who are presented with a sickle cell crisis. Exchange transfusion. Exchange transfusion is where the entire blood of the patient is removed and replaced with another blood. This is known as exchange transfusion. Exchange transfusion is usually required if the patient is presented with a stroke or acute chest syndrome. May be required if the patient is having an splenic sequestration or priapism, may be required in those conditions. Remember that cholelithiasis is one of the recognized complications because of a sickle cell disease. Okay, they might ask which one of the following is a complication of a sickle cell disease. Cholelithiasis, you might be just thinking of a vaso-occlusive crisis, acute chest syndrome, splenic sequestration. They might not mention any one of those, and they might have mentioned cholelithiasis. At that point of time, you might have to pick up an cholelithiasis. So be aware of it and pick up an cholelithiasis in those conditions. DIC stands for disseminated intravascular coagulation. Two things might happen here. One is activation of coagulation system. Another one is activation of fibrinolytic system. Activation of coagulation system will result in what? Formation of clots. So it can form thrombus and clots everywhere in your body, resulting in infarctions. It can cause it can activate fibrinolytic symptoms, resulting in bleeding. Small clots keeps on forming every day in and in out to stop the injuries which have happened to your vessels. So autocorrection will be happening there. So if these clots get dislodged, what will happen? The bleeding will occur. So he starts having bleeding. So these patients can present with two extremes, where one side you are seeing the clot formations, another side you are seeing they're extremely bleeding. So what are the causes for this? It can be because of any infections. It can be because of cancer like adenocarcinoma, lymphomas, acute leukemias. It can be because of trauma. It can be because of pregnancy related like an HELP syndrome, abruptio placenta, or an amniotic fluid embolus, or an abortion which is septic. It might be because of a snake bite. It might be because of an ARDS or acute hemolytic reactions also can lead to an DIC. Symptoms, as I told you, it can be hypercoagulation symptoms, commonly seen in patients who are having sepsis and developing a DIC, who are having cutaneous gangrenous or thrombotic purpura they will present with. Okay, because of hypercoagulation. Coagulation. Hyperfibrinolysis is commonly seen in leukemia. They will be presenting with bleeding disorders like oozing from the IV set, this bleeding from the where the IV cannula is inserted. They might be having bleeding from and genitourinary tract resulting in hematuria. They can have petechiasis, ecchymosis they can present with. There is a condition known as purpura filaments. Okay, it is a life-threatening condition usually seen in a meningococcal sepsis. They present with a non-blanching rash. Okay, this rash will be necrotic over the time and it is an emergency. Treat these patients immediately. What are the lab investigations? Platelets are consumed, so it will be lower side. Clotting factors are consumed, so the prothrombin time and APTT time will be prolonged. Fibrinogen levels usually will be on the lower side. Fibrin degradation products and D-dimers, clots can break down, so they will be elevated. Activated, that is APTT, and usually prolonged. So what you will be doing here? Symptomatic treatment. What is the underlying cause? Treat the underlying cause first. Along with it, if the platelet is less than 50, you platelet transfusion. Prolonged PT and APTT, you FFPs. Persistent low fibrinogen levels, especially less than 1.5, then give fibrinogen concentrate. Prolonged APTT, vitamin K you can think of, along with FFP if it is severely prolonged, especially the INR is more than 1.5, then yes, FFP will be preferred in those conditions. If it is a thrombotic event dominant clinical feature, where clots are forming a lot, infarction is happening because of that, then low molecular weight heparin can be given. Trauma-related TIC, then consider giving tranexamic acid. As I told you, within 3 hours of the incident, you need to give tranexamic acid. Stat 2 grams can be given according to the latest 11th edition. Red flags for back pain we are talking about. So what are these red flags? What are we worried about? We are worried about, can it be a vertebral fracture? Can it be a tumor? That's why he's having an back pain. Can it be a spinal infection or cauda equina? Or is it an inflammatory rheumatic disease which has predisposed or made the bones very brittle, resulting in a fracture? So we are worried about those things. So you are looking at those things by looking at the red flags. If those things are not present, back pain is a very common presentation to the ED department. What do you do for the back pain? You give a symptomatic treatment and you can discharge this patient. So the things you need to look out for is vertebral fractures. A trivial trauma resulting in a vertebral fracture. Where can you see? Anyone who is taking a prolonged steroids can result in osteoporosis, resulting predisposing to an vertebral fracture. History of trauma, obviously you can suspect in vertebral fracture in those conditions. Tumors. Tumors is a CA. CA and malignancies are commonly seen in extremes of the age, either in the less than 20 or more than 50 years of age. You need to closely look for any weight loss histories present in this individual, and usually they will be quite sick, systemically unwell there will be, and usually it will be a metastasis, like in prostate CA metastasis to lumbar vertebrae. Spinal infections. Spinal infections, we have touched about this in the infectious chapter, if I'm not wrong, where I discussed about the epidural and subdural abscesses. These are commonly seen in IV drug abuser. So in the stem of the question, most of the time they will mention an IV drug abuser. Along with it, these patients will be having fever. Okay. Because it is an infection, it is an abscess I'm talking about. Fever, high grade fever will be there. And these patients might be immunocompromised. Pain will be worst at the nights, and non-mechanical pain is commonly seen in both tumors and in the abscess. Non-mechanical pain, that means even at rest, they are having pain. Cauda equina, we'll be discussing in detail about the cauda equina in coming up slides. Triple A, any elderly patient, especially more than 50 years, and the patient is a smoker, you need to always do an bedside ultrasound scan done to see whether it is a triple A, which stands for abdominal aortic aneurysm. A pulsatile mass can be seen, but these individuals will be very sick. And I'll be talking in detail about the triple A in vascular emergencies. In coming up chapters, vascular emergencies. Inflammatory rheumatic disease. The most important one, what you need to be aware of, is ankylosing spondylitis, which we already learned about, which commonly presents with an bamboo spine. This spine is brittle and they can present with a fracture even with a trivial trauma, or just movements can result in a fracture in these individuals. If the individual is having any one of this, then you need to further evaluate in the emergency department. The clinical features which are more suggestive of a nerve root pain. Okay, it is a root pain what you're talking about. The pain radiates down, right down into your foot and into your toes. Numbness is distributed in the nerve root. Okay, in the nerve root, in those nerve roots, for example, it is a L5 what you're talking about. So in the dermatomal distribution, it will be present. Straight leg test usually reproduces the pain. Localized neurology at one nerve root can be present. Discitis is nothing but intervertebral disc what is present here. This disc between the vertebrae what I am talking about, if it gets inflamed, then it is known as discitis. Okay, if you're suspecting, then do get an MRI scan done and get the inflammatory markers like WBC, ESR, and CRP in these individuals. You'll be treating with Inflammation, most of the time the inflammation is because of infection, bacterial infection. IV antibiotics and refer them to the neurosurgeons. Spondylolysis and spondylolisthesis. Okay, they may not test you in this depth, but it's better to have an idea. Spondylolysis is an defect or a fracture at this site. What is this site is known as? This is known as pars interarticular. Sorry, this is known as pars interarticularis. This is pars interarticularis. So whenever there is a defect or a fracture, then it is known as spondylolysis. Spondylolithiasis, we call it whenever there is a defect at pars interarticularis which has resulted in slipping of the vertebrae in front compared to that of the lower vertebrae. It is moved a little bit forward. It is not in the alignment. Then we call it as in spondylolithiasis. That's the main differentiating factors. Management for just spondylolysis, where there is no displacement, what you are seeing it, this rest physiotherapy and activity modification. That's all, nothing specifically you'll be doing. There is a mild displacement, conservative management. Severe displacement, then surgical intervention will be required. Commonly, it is the lumbar vertebrae which are involved here. Lumbar vertebrae are the ones which are commonly involved. What is the management? Non-traumatic vertebral fractures, for example, due to osteoporosis. What do? You just do and conservative management. Commonly seen in postmenopausal women here, spine support and conservative management, nothing specifically. Intervertebral disc prolapse, if they are presented with, you have two options. Either you can do a surgical discectomy or micro discectomy. One is not superior over the other one. This is better than doing and conservative management because it helps to relieve the acute attacks. Okay, it is much better than doing in conservative management, faster relief from the acute attacks. Just a simple back pain, nice guideline says just give NSAID, that will be sufficient. You can add up and muscle relaxant like low doses of diazepam can be given, plus or minus physiotherapy will be required. It is advised that you mobilize these patients as soon as possible. Usually they start recovering within a month's time and they recover completely within 3 months' time. Okay, so most of the time, that is 82% of them can return back to the work in a month's time. 93 of them usually return back to the work in 3 months. The rest 7% of them might require more time for them to return back to the work. Sciatica, any impingement of the lumbosacral nerve, okay, will result in sciatica. Basically, sciatica means impingement of the nerves. It is commonly seen in lumbar region or the sacral region. So that is lumbosacral region. This is what you are seeing is the compression. Impingement means compression of the spinal nerve. As it gets compressed, the pain is radiated right from the back, from the buttocks to all the way down to the toes. It gets radiated too. Straight leg test will be positive in these individuals. Okay, if it is a bilateral slide leg test which is positive, that is bilateral sciatica, can predispose to cauda equina. In those conditions, it is recommended that you go ahead and get an MRI scan done. If it is just a sciatica, pain management, no imaging, you are doing it, physiotherapy. Okay, so pain management, what you're doing, depending on how severe the patient has presented with. Studies have shown that just giving a placebo also might be as effective as giving an NSAID like ibuprofen or diclofenac. This pain, in what direction the loss of sensation will be there, is the termatomal distribution. Termatomal distribution depends on which side it is involved. L1 is the loss of sensation around the groin region. S2, posterior part of the thigh. Around the perianal region, we are talking about S3, S4, and S5. So in this manner, this picture will help you to remember. POTS disease, also known as spinal tuberculosis. What happens here? It's a tuberculosis. So it has to be caused by Mycobacterium tuberculosis, and the spread is usually via the blood. That's why it is known as hematogenous spread. The most commonest site is thorax, followed by lumbar, followed by cervical region. If this patient presents with an loin mass and pain with hip flexion, then it is more suggestive of an psoas abscess caused by again Mycobacterium tuberculosis. It can cause. They often do not present with cough, weight loss, and night sweats, which is commonly seen in tuberculosis. So it is an extra pulmonary manifestation of tuberculosis. Whenever it is an extra pulmonary outside the lungs, it is present. Then most of the time, they do not have cough, weight loss, and night sweats. They just present within pain in the thoracic region. That's the most commonest site. For this patient, when you're suspecting an spinal infection, then you need to get an MRI scan done. It becomes the modality of choice. Drugs, what you'll be giving, antitubercular drugs. Surgical reference will be required if there is a cord compression or spinal instability or a large abscess is formed because of the tubercular infection. Metastatic spinal cord compression. Okay, again, it is commonly seen at the thoracic region or at the upper cervical region, followed by the lumbar region, what they'll be having. Usually, pain gets aggravated by straining, moving around, working out, the pain becomes worse and worse. And when you just palpate the spine, it will be tender to palpate. And during the night time, the patient might wake up because of this severe pain. What do? Get an whole spine, because if there is a metastasis to the thoracic, there might be to the cervical also. So it is better to screen the whole spine. So get an whole spine MRI scan done within 24 hours. It's not immediate, within 24 hours. Do not get X-ray done. They're not helpful at all. It's not performed. It is not helpful. Directly go for an MRI scan done. What do you do in the emergency department? Symptomatic management, along with the main important one, is to give dexamethasone 16 mg. Why we are giving dexamethasone? Here, what has happened due to the metastasis, the cancer is there. Acutely, why they are having symptoms? Because edema is developed around it. Because of development of the edema, this patient has acutely presented to the ED department with this complaint of pain and spinal cord compression. So you will be giving dexamethasone 16 mg to reduce the edema. That is important from the emergency point of view. Then you will be involving the MCC here. This is basically metastatic spinal cord compression. Coordinators will be present. You involve them. They will take a call whether to do an surgical management or go for a more palliative radiotherapy. That call will be taken by them. The coordinator will coordinate with the oncologist, with the spine surgeon, and take a call what next to be done. Cauda equina syndrome. Cauda equina syndrome is basically compression of the nerve roots. Once the spinal cord ends, below this, the nerve roots runs in this manner. From the lumbar and sacral region, they'll run. Whenever there is a compression at this, then it is known as Cauda equina syndrome, which is a true emergency. The sooner you intervene, the better the prognosis will be here. What are the causes? What are the causes for the compression at the conus medullaris? After the termination of the spinal cord, the nerve roots which are running downwards, that is known as conus medullaris. What are the causes for the compression there? It might be a disc prolapse, it might be tumor, or it might be because of severe ankylosing spondylitis or osteoarthritis, which is resulting in spinal stenosis. It might be due to an epidural abscess or epidural hematoma, especially seen post-spinal anesthesia, or it might be direct trauma, or it might be an abscess. Clinical features depends on which nerve root is involved. But classically, how do they present with? What do you need to look out for in the stem of the question? In the stem of the question, you need to look out for is loss of perianal sensation. Okay, that is important. Loss of perianal sensation. Are you looking for those things? Yes. Loss of anal tone in this individual. Next important thing. Then bowel and bladder. Bowel and bladder disturbance we are talking about. That means they can present with bowel and bladder incontinence, or they can present with a constipation or acute retention of the urine. Either ways, they can present to the emergency department, along with bilateral lower limb neurological deficit. It can be a motor or it can be a sensory neurological deficit, but it is bilateral involving both the legs. That's why I'm calling it as a bilateral. These are the four things what you will be looking out for. Management. Management, get immediate MRI scan done. The sooner the better. Once you get an MRI scan done, immediately involve the spine surgeons for spinal decompression. The sooner you intervene, the better it is. If you delay it more than 48 hours, the damage is permanent. You cannot do anything after 48 hours. Most of the time, it is a poor prognosis. So immediate MRI scan done, immediate involvement of the spine surgeons, and intervene as soon as possible to do an surgical decompression. These are the things what you need to really look out for in this individual. Tumor lysis syndrome. Tumor lysis syndrome is very much similar to that of the rhabdomyolysis. Rhabdomyolysis is breakdown on the muscle fibers. Here, breakdown of the tumor cells. So everything is very much similar. So this patient will present with high urea levels, high phosphate levels, Low calcium because calcium get deposited over the broken cells. Hypercalcemia because inside intracellularly the sorry hyperkalemia, that is high potassium levels. Potassium levels are very much high inside the cell. So once they break down, they spill out into the normal circulations, resulting in hyperkalemia. Mainly the supportive management by giving IV fluids in these individuals. Hemodialysis might be required. Okay, if IV fluids are ineffective, then you're directly going for dialysis in these patients. Same treatment what we discussed for rhabdomyolysis, no difference. Same complications what we discussed for rhabdomyolysis, no difference. The differentiating factor here is here breakdown of the tumor cells. What you're seeing in rhabdomyolysis, there is breakdown of the muscle fibers. Superior vena cava obstruction. Okay, there is a superior vena cava and an inferior vena cava which gets back the deoxygenated blood into the right side of the heart. Okay, that's what mainly happens. Here, what is happening, as the name suggests, there is an obstruction to the superior vena cava. Why does this obstruction happen? Most of the time, it is because of the apical tumor, what you see, apical tumor of the lungs, CA lung, especially when the apex is involved. Sometimes it might be because of an external compression, thrombus, or direct invasion, but most of the time it is in lung CA. How do they present with? They present with swelling of the face, swelling of the upper limb, swelling of the upper part of the chest. Why swelling? Because venous return is not happening. Venous return is not happening. That's why the swelling is developing. Along with it, the collateral veins get start to collateral veins which are present, they starts getting dilated. With this, they can have breathlessness, shortness of breath, dizziness, visual changes can present along with this. But the main thing is swelling of the face, neck, and head and upper limbs. Those are the classical features what you need to pick it up whenever you are suspecting in superior venical obstruction. Most common cause is apical cancer. Diagnosis is mainly clinical. Sometimes imaging might be required, which will be helpful for you to suggest whether there is a compression or there is no compression. So mainly supportive management, use steroids acutely if they are presenting with. That means there is an edema which has developed around the cancer. If this is the lungs, here the cancer, edema is developed. This edema is basically causing the compression. That's why they are acutely present. So giving steroids will be helpful. Radiotherapy, chemotherapy, this call will be taken by the oncologist, not by you. So you're just referring to the oncologist. Stenting is required or not. Again, it is a multidisciplinary call about the stenting. From emergency point of view, steroids and supportive management. Two S's, there's a steroid and supportive management, what you'll be doing. Autonomic dysreflexia, a very important topic, what you need to be aware of. So for an autonomic dysreflexia, there should be an trigger agent and there should be an spinal cord injury. The spinal cord injury should be above the level of T6. This is important. Why? Above the level of T6 is the where you find the sympathetic chain. So sympathetic chain needs to be affected here. So above the level of T6, there should be an injury present in the individual and there should be a trigger agent. This trigger agent will do what? This trigger agent will usually increase the sympathetic activity. By what? It might be a bladder distension. Sorry. What are the triggering agents this patient might have? This patient might have the triggering agents like in bladder distension. Commonly because these patients will be catheterized because of the urinary incontinence, spinal injury they are having, this catheter would have got blocked. Because of the blockage of this catheter, bladder gets distended and they start being a triggering agent to trigger the sympathetic increase in the sympathetic activity. It might be because of constipation, or it might be because of an ulcer or tight fitting clothes, or because of an pain due to a burn, fracture, or surgical wound. So anything which triggers the sympathetic tone. What happens? Once sympathetic tone is triggered, stimulated, there will be increased in blood pressure and increased in heart rate. This just ignore it. So there will be increase in blood pressure and increase in heart rate because sympathetic tone is triggered by an triggering agent. Sympathetic tone is increased by an triggering agent. The increase in blood pressure is picked up by baroreceptors. So your body realizes there is increase in blood pressure, which is not required in this situation. Let me reduce the blood pressure. So increase in blood pressure is picked up by the baroreceptors, sent to your brain, and your brain starts reducing. How does it reduce? It wants to reduce the heart rate. Heart rate is fine because the spinal cord injury, heart rate is fine because it is carried by the vagal nerve, which is present in the neck one of the cranial nerves it is. So heart rate will fall down. What about the total peripheral resistance? That is nothing but vasodilatation. The signals are sent to the upper limb. So upper limb, the signals have gone. But the lower limb, the signals cannot come because there is a spinal cord injury. So they cannot cause vasodilatation of the lower limbs where major vessels are present. So the blood pressure will come down, but it will never come back to the normal range. So slightly on the higher side at the upper limit, the blood pressure will be. So blood pressure on the higher side and low heart rate. Okay, borderly low heart rate we are talking about, not significantly low, not significantly high blood pressure. So borderline higher blood pressure and borderline bradycardia these patients will have, along with it a spinal cord injury, a triggering agent. So in the stem of the question, what you need to really look out for? A triggering agent, a spinal cord injury, heart rate on the lower side, blood pressure on the higher side. If this is present, then it is known as autonomic dysreflexia. They might ask you what might be the cause. These are the causes for autonomic dysreflexia, a triggering agent. What is the treatment? Treat the cause, what is present here. So now we'll be discussing about the questions. So the first question what we are having is a 70 years old bar fight sustained multiple injuries. Blood pressure is 80/40. You activated the major hemorrhage protocol. He is known case of AF on dabigatran. While waiting for the blood pressure, what is the next step? Next step will be to just reverse the dabigatran what the patient is having. How do you reverse the dabigatran what this patient is having? Anyone wants to answer? Can write their answers in the meeting chat. Again, let me repeat. Anyone wants to answer can write their answers in the meeting chat. So the right answer here is idarucimab. Okay. It is a reversal agent. Idarucimab is the right answer. Next one, we are having a patient, elderly patient present to the ED with complaints of lower back pain and weakness in the lower limbs. MRI scan of the spine shows metastatic spinal cord. What is the next best step in the management? Metastatic spinal cord, we need to reduce the edema by giving dexamethasone. That is one of the important steps what you need to be aware of. So the right answer here is to give dexamethasone 16 mg. So those also you need to be aware of. An elderly female complains of burning maturation with an increased frequency of maturation. A diffuse rash is seen all over the body, and these are the vital parameters they are given. D-dimer is elevated, PT-APTT is prolonged, INR is also prolonged, CRP is on the higher side, WBC on the higher side. So most likely it looks like sepsis. An urinary tract infection has led to the sepsis. Sepsis has led to the DIC. So the diagnosis here is disseminated intravascular coagulopathy. What is the mechanism of action of dabigatran? It kind of inhibits the factor 2, which is also known as thrombin. So they can interchange the names, be aware of it. Thrombin and factor 2 is one and the same. Complaints of shortness of breath, hemoglobin is on the lower side. You started on the blood transfusion because hemoglobin is on the lower side. She started immediately complaining of pain at the IV side. Vital parameters are dearranged. What are you thinking about? Okay, whenever the patient is unstable and especially pain at the IV side, always think of ABO incompatibility, which is also known as acute intravascular hemolytic reaction. Immediately stop the blood transfusion in these patients. Which of the following is an antidote for rivaroxaban? Adirondack alpha is the right answer here. A 3 years old child, history of slip and fall, sustained an injury to the head, and he is known case of hemophilia. Slap hematoma measuring 6 centimeters and chest bruising is seen. Vital parameters are given. What is the next step they're asking? This scalp hematoma, what is present, can keep on getting enlarged. So you need to first address this scalp hematoma, what the patient is having. So how do you address the scalp hematoma, what is present here? He's a hemophilia. How can you treat it hemophilia? By giving factor 8. Whenever they do not mention hemophilia A or B, it is, if they are not mentioning A or B, always consider it to be an A. That is factor 8 deficiency. You this patient factor 8. The next question is, why not get an urgent CT scan done? Urgent CT scan is usually advised if the GCS is less than 14. Okay, DGS is less than 14 on initial assessment in a child of more than 1 years old. That is not the scenario here. So it doesn't require immediate CT scan here in this individual. A 70 years old with an hemoglobin being 4.4 grams. After 45 minutes of transfusion, vital parameters are shown here. Only the temperature is on the higher side. What is the diagnosis they are asking? He's stable. Delayed means delayed, it will be presenting and the patient will be stable. It is not a delayed reaction what is happening. Anaphylaxis, the patient will be unstable. ABO incompatibility or acute intravascular hemolytic reaction, both are same, they'll be unstable. Here it is stable. That's why it is an febrile non-hemolytic transfusion reaction what the patient is having. Vomiting that contains blood, and that means upper GI bleed the patient is having, and the patient is in shock, hemoglobin is low, fibrinogen levels are more than 1.5, they're not low, so this is fine. Platelets are fine, INR is also fine. What this patient requires? PR basis. So what we need to choose an option which has only PR basis. So the option which has only PR basis is option number 2. A 8 weeks pregnant lady present to the ED department complains of headache and sweating. For there is a past medical history of spinal cord injury, and on long-term catheter, no urine is noted in the urobag. History of not opening bowels since last couple of days, and the patient is having low heart rate and borderline blood pressure. What is the diagnosis? So does it satisfy everything? It looks like no urine in the urobag. That means there is a trigger agent which is suggestive of an acute retention of urine. Spinal cord injury. Yes, spinal cord injury is present along with low heart rate and slightly high blood pressure. Everything is satisfied. That's why it is an autonomic dysreflexia in this patient. 8 weeks pregnant, same question. 8 weeks pregnant lady, same thing they have asked. What is the most appropriate next step they are asking? Treat the most appropriate step. But here, they specifically mentioned that bladder is empty on the ultrasound scan. That means the catheter is not blocked in this. Is not blocked. Bladder is empty. It is not the acute retention of urine. The catheter is fine in this individual. So what we need to look out for here? We need to look out for what is the trigger agent and treat the trigger agent. So it might be the check for pressure ulcers and address any painful stimulus. That will be the right answer here. Give IV fluids to improve the perfusion or replace urinary catheter. It is not blocked. Many people choose this. This is not blocked to replace it. That is not the right answer. Perform an MRI scan. No, not required. It is a clear cut the diagnosis of an autonomic dysreflexia. Treat the triggering agent. The triggering agent here might be pressure ulcers. If there are any painful stimulus, address that and treat it. That will be the right answer. Giving IV labetalol for blood pressure control, this is not very high. And if you give IV labetalol, it's a beta blocker, it will cause bradycardia, can go into complete heart block. A young male was involved in a road traffic accident and intubated. The blood pressure is on the lower side. Fluid of 500 ml of Hartmann fluid is given and 2 units of O negative blood transfusion is done. His blood pressure has improved to 90/60. Patient continues to have an tachycardia. What is the next step they are asking? Okay, if you remember the trauma class, I told you, if the blood pressure has improved to 90/60 borderline, do not transfuse the blood till it is cross-matched. Okay, if it is required, you can wait. You buy time till it is cross-matched. Okay, because we do not want any transfusion reactions and complicate the present case what is present. You have enough blood pressure, so you can wait for another few minutes. Usually it takes 25 minutes for the cross matching of the blood. Wait till it is available. Once you have the cross match blood, then you can transfuse more. Elderly female complains of rectal bleeding, weight loss of 1 stone in a month, APTT is prolonged bleeding time. What is the most likely cause they are asking? First, let us address what do I mean by 1 stone. 1 stone is a usual terminology what is used in UK, which equals to 6.35 kgs. 1 stone is 6.35 kgs. What might have happened? Why the patient is having only prolonged APTT in this individual? Factor 5 deficiency. Does it cause prolonged APTT? No. 1 millivan factor. Yes, it can cause prolonged APTT, but it also causes prolonged PT. CML is not involved here. Acquired hemophilia and hereditary hemophilia both can cause this. Hereditary means it will not be in the elderly, would have already diagnosed it by the time of this age. So unlikely to be hereditary. So you can rule out and come to a diagnosis of acquired hemophilia here. So what exactly might be happening here? Per rectal bleed with weight loss. So you're suspecting an colon CA. This colon CA can act like an paraneoplastic syndrome. If it acts like a paraneoplastic syndrome, can result in factor 8 deficiency, clotting factor 8 deficiency, resulting in acquired hemophilia in these individuals. That is what exactly is happening in this individual. But this is unusual for you to pick it up in the exam. Then start ruling out options like I have ruled it out in the exam. That will be the best way to approach this kind of questions. A 67 years old female was brought to the emergency department. She is on antibiotics for recurrent urinary tract infections. Saturations are 99% on 5 liters oxygen. Temperature is on the higher side. WBC is elevated. CRP is elevated. INR is on the higher side. PT and APTT prolonged. D-dimer is on the higher side. Diagnosis. To be very simple, again, urosepsis leading to an DIC in this individual. So the right diagnosis is DIC. A 6 years old boy was brought to the ED department with complaints of multiple episodes of epistaxis and bleeding from the gums. Platelet count is on the lower side. Bleeding time is prolonged. What might be the diagnosis they are asking? The diagnosis here is idiopathic thrombocytopenic purpura because in von Willebrand factor, APTT will be prolonged. That's how I ruled it out. In hemophilia, only APTT will be prolonged. Okay. Again, APTT seems to be in the normal range. Normal APTT will be prolonged. That will be normal range. I have ruled out. But what about thrombotic thrombocytopenic purpura and hemolytic uremic syndrome? Let us study more about this one. Thrombotic thrombocytopenic purpura and hemolytic uremic syndrome both are kind of very similar to each other. Okay. Hemolytic RBCs will be on the lower side. That's why anemia. RBCs will be on the lower side, anemia. Uremic, urea gets accumulated whenever there is a renal failure. So these patients will have acute kidney injury, acute kidney injury. We're talking about low platelet counts. That's why these patients will have thrombocytopenia, thrombocytopenia. This all three what we have discussed is same. But HUS is commonly seen in children, whereas TTP is commonly seen in middle age group. In TTP, you usually see fever with CNS symptoms. Here, usually they do not have an fever. They're usually present with a bloody diarrhea that is caused by E. coli, a subgroup of E. coli known as EHEC, okay, which we have discussed in the gastroenterology chapter, which can cause an hemolytic uremic syndrome. Here, there is nothing suggestive of an TTP or an hemolytic uremic syndrome. They didn't suggest of an acute kidney injury. Thrombocytopenia is present, but no acute kidney injury. And the WBC counts or the hemoglobin is in the normal range. That kind of rule out both of this criteria, and ITP becomes the right answer, idiopathic thrombocytopenic purpura. Young male present to the ED department with a lower back pain and numbness over the right foot since the couple of days. His neurological examination including anal tone is unremarkable. What is the next step? My question is there any red flag for the back pain what the patient has presented with? No, there is no red flag. Just having a numbness over the right foot for the last couple of days. Why? We need to get an MRI scan done to really find out. Do we need to get an immediate MRI scan done? Answer is no, because there are no red flags. If there are no red flags, then there is no need to get an MRI scan done on an immediate basis. So discharge this patient and get an urgent outpatient MRI scan done. That should be sufficient in this individual. Which of the following is an early symptom of an CA prostate? There is no specific literature which says which one is the early symptom. But if you use the common sense, most of the time, CA prostate it is involving the urinary tract. So most likely it is the difficulty in maturation should be the one of the first symptoms what this patient will be presenting to the emergency department. A 34 years old male present to the ED department with a severe back pain. He wakes up in the night with a pain and he is an IV drug abuser, high body temperature. What is the best diagnostic modality was the patient? So IV drug abuser with lower back pain and a high grade temperature, all put together, what are we suspecting here? We are suspecting an spinal infection. To be more precise, we are suspecting an spinal abscess in this individual. Whenever you are suspecting a spinal abscess, get an MRI scan done. So the red flags, what we have learned, in all the red flags, except if you're suspecting a fracture, in all other red flags, it is advised you to get an MRI scan done. Cauda equina, get an MRI scan done. Spinal infection, get an MRI scan done. Metastatic spinal cord, metastatic spinal cord compression, get an MRI scan done. Um, or an tumor of the spinal cord you are suspecting, get an MRI scan done. Only in fractures, For example, you're thinking of a fracture because the patient is on steroids. You're thinking of a fracture because he's a known case of ankylosing spondylitis. In those circumstances, getting an X-ray or a CT scan makes sense. Otherwise, always go ahead with an MRI scan done. So the right answer here is an MRI scan. Young postpartum lady numbness of the bilateral lower limbs associated with a lower back pain. Not open her bowel since 2 to 3 days. What is the diagnosis they are asking? Pregnancy or not pregnancy doesn't matter. Sorry. Pregnancy or non-pregnant doesn't matter. A lower back pain the patient is having plus bilateral neurological symptoms of the lower limbs is suggestive of an cauda equina until and unless proven otherwise. So immediately get an MRI scan done, then involve the spine surgeon. A road traffic accident, 40 years old. His observations includes blood pressure which is in the shock, recheck blood pressure still in the shock. Okay, and the hemoglobin is on the lower side. What is the next best step they're asking? What you will do in this individual? The individual is in shock, so you need to resuscitate. What is the best fluid to resuscitate the patient with an hemorrhagic shock? To give the blood. So what blood you are giving? The hemoglobin on the lower side. What blood product will be preferred in this individual to give PRBC? INR is fine. It is not more than 1.5 to give an platelet. PT and APTT are in the normal range to give an FFP. That's why I'm choosing a PRBC over any other option. Increased frequency of maturation and decreased appetite on and off since a month. History of weight loss is present. On no history of OCP use in her entire life. Mass is felt in the left lower abdomen. What is the diagnosis? We are thinking of an CA. Everything is given of an CA here. Bladder, endometrial carcinomas, breast CA. This can be ruled out because the mass is seen in left lower abdomen. Usually suprapubic mass will be seen or something suprapubic or middle lower abdomen. In the middle you will be seeing in an bladder CA or endometrial CA. In a breast CA, it will not be in the lower abdomen. It will not be on the left side or right side or in the lower abdomen. Same thing here, middle of the lower abdomen, you will be seeing the mass. So we are left with an colon CA and ovarian CA. They are specifically mentioned about here the patient not taking OCP in the entire life. If they take an OCP, it is protective against an ovarian CA. As they are not taken an OCP in entire life, we are more thinking of an ovarian CA in this patient rather than an colon CA. Colon CA usually will present with bleeding per rectum or constipation or an bowel obstruction. Those symptoms are not here. That's why we rule out an colon CA. Remember that if someone takes OCP, it is protective against an ovarian CA, but it increases the rates of breast CA. Someone who takes the OCP has an increased rates of breast CA. Most common complication with a massive transfusion is hypocalcemia because blood is stored in an citrate medium. And massive transfusion, we call it if you're taking more than 10 units in 24 hours or you have transfused 4 units in an hour's duration. A 76 years old female complains of shortness of breath. Hemoglobin is on the lower side. So you are started on the blood transfusion. Complains of pain at the site of the IV line. And the vital parameters are on the lower side. What I am suspecting? I am suspecting an ABO incompatibility, also known as acute intravascular hemolysis. That is not mentioned here. That's why I'm forced to choose whether it is an immune or non-immune. It has to be an immune. Only one thing is non-immune, that is an fluid overload, transfusion-related fluid overload. So this has to be an immune-mediated transfusion reaction. I'm not suspecting an infection or sepsis on the cannula side or an bacterial contamination because the pain at the IV side helps to differentiate from the bacterial contamination. Nosebleed, the patient is on warfarin. What is that? Nosebleed is a minor and it is more than 5. So we stop the warfarin and give vitamin K IV. Stop is there vomit even dose. So which one to select? Which one is more important? Giving the vitamin K is more important. Vomiting you can tell later also. Okay, so the next step is to give the vitamin K. Then you can tell to vomit the evening dose. Routine blood workup found out that the INR is on higher side 7.2, no bruising, hematuria or mucosal bleed. That means there is no bleeding, INR is on the higher side. So what we'll be doing in this condition? You stop the warfarin and recheck the INR after 2 days. That is it. Because it is in this range where it is 5 to 8 range. 7.2 comes between 5 to 8. That's why you're stopping the warfarin, repeat it once in the therapeutic range, then you can restart it. A chronic smoker with an swollen face, neck, and upper limb as presented to the emergency department. X-ray has been given. What is the most likely diagnosis? X-ray, there seems to be a mass in the apical region. Swelling over the face, neck, upper limb is more suggestive of an obstruction of an superior vena cava. Why does this obstruction usually happen? Because of a cancer, apical cancer of the lungs. So the right answer here is a CA lung. A 44 years old male complains of mild abdominal pain and lethargy. And WBC counts are on the higher side and predominantly blast cells. So blast cells, I'm thinking of acute. Middle age, it has to be AML, that is myeloid leukemia in this patient. So right away, I can pick up the diagnosis as an acute myeloid leukemia. Predominantly blast cells means it will be more than 20%. You need to consider that. 81 years old male complains of lower back pain. He is a known case of CA, prostate tenderness in the lumbar vertebrae. You are suspecting in metastatic spinal cord. The first sign is whenever there is a metastatic, what will happen? First, it will develop the pain. Okay, metastatic spinal cord compression it is causing. That's why pain is the first symptom. Later on, it can cause compression over the spinal cord and develop any one of the symptoms. A 13 years old kid has a sore throat and PTK. That means has a viral infection. Why PTK? There must be low platelet count. Yes, the low platelet count. Bleeding time is prolonged. It is all suggestive of what? Viral infection plus low platelet. Always suspect an ITP in this individual. So the right diagnosis here is ITP. You can always rule out rest of the options by looking at the investigations what has been provided. For example, here in hemophilia A and B, because APTT is in the normal range. Von Willebrand factor also can be ruled out because APTT is in the normal range. In that way, easily you can rule out the other parameters. Same thing, factor 5 deficiency is also ruled out because both APTT and PT is in the normal range. A 61 years old female presented with an per-rectal bleed. Blood transfusion you have done. Soon after the transfusion, the patient develops chills and fevers. What is the next step they are asking? All the vital parameters what they are given are stable. Okay, so what are we suspecting in this individual or what you will be doing? We do not know. Have you rechecked the blood pressure? No, we have not checked the blood pressure. We have not checked the vital parameters. So what you will be doing as the first step? First step, stop the transfusion. It might be mild reaction or a severe reaction. We always stop the transfusion first. Then let us assess whether it is an ABO incompatibility or in bacterial contamination, or it is a simple non-hemolytic febrile reaction what the patient is having, or it is might be a mild allergic reaction. We do not know. First stop the transfusion, then assess, and then take a call. You suspect an cauda equina. Which one of the following will support your diagnosis? A shooting pain, weakness in one limb, no bilateral it has to be. Pain radiating from back to the toes, suggestive of sciatica. Stiffness at the back is more suggestive of muscle spasm. Loss of anal sensation or anal tone is the right answer. Loss of anal tone along with loss of anal sensation and perianal sensation are more specific for an cauda equina. Sickle cell anemia, complaints of chest pain and acute shortness of breath since morning. So what are we suspecting? We're suspecting an acute chest syndrome until and unless proven otherwise. Why? Sickle cell anemia patient presenting with any chest syndrome, it has to be an acute chest syndrome until and unless proven otherwise. So what is not included in the management? Do we give antibiotics? Yes. IV fluids? Yes. Analgesia? Yes. Blood transfusion? Yes, might be required. What about bronchodilators? We do not give bronchodilators. So it is not included in the management in acute chest syndrome. A 75 years old male fallen onto the edge of the table 6 hours ago. CT scan reveals and liver lacerations. Blood pressure is on the lower side. Hemoglobin is falling down. Platelet is fine. INR is fine. AMREX protocol is activated. 2 units of O negative has been transfused. What is the next step they are asking? The patient's what is the blood pressure? Blood pressure is still on the lower side. So what do we need to do? Continue resuscitating with the blood products, which will be the plus one. Hemoglobin is falling. Platelet is fine. INR is fine. So FFP and platelets are not required for this individual. Requires is the PRBC. So we are selecting an option which has an PRBC. So this one is the right answer. Nowhere they are mentioned the patient is on warfarin to think of PCC. FFP platelets I have discussed here. What about giving 1 gram of tranexamic acid? It has been more than 3 hours. It's been 6 hours ago. That's why we are not giving tranexamic acid in this individual. Hematemesis and melena, the patient is presented with, we are suspecting upper GI bleed, in shock. Which statement regarding the management is correct? They are asking. Vitamin K should not be given due to his mechanical wall. No, there is no contraindication if he has a mechanical wall. This is a wrong statement. Only O negative blood should be given in the initial resuscitation. Yes, if you're not cross-matched, it is the right statement. Let us see anything more right answer might be present. Platelet transfusion should be given if the platelet count is less than 50, no, less than 50,000, not 60,000. Prothrombin complex cannot be given before an INR is known. Not true. If the patient is on warfarin and does plus has a major bleed like an GI bleed in this situation, doesn't matter what is the level of INR. You can go ahead and give prothrombin complex. Tranexamic acid should be administered in an upper GI or GI bleed. Tranexamic acid is not advised. So the most right answer out of the option what is given is this option number 2. Remember, tranexamic acid should not be given in an GI bleed. It is not effective. Nose bleed, that means it is a minor bleed what the patient is having. Hemoglobin on the lower side. APTT is prolonged. Prolonged bleeding time is also present. So whenever there is an APTT prolonged plus there is a prolonged bleeding time, what are we suspecting? 1 milliband factor deficiency we are suspecting in this individual. This is the right answer, option number 4. A 72 years old present to the ED department with the lower back pain, paresthesia in the anal region, complaining of urinary incontinence, lower back pain, paresthesia in the anal region, that is perianal sensation loss, urinary incontinence, is all suggestive of an cauda equina syndrome. So for cauda equina syndrome, the first next step, best step will be to get immediate MRI scan done. After that, involve the spine surgeons. Hemophilia A patient, he fell and had an injury to the head. Continuously bleeding from the scalp even after applying pressure. Which of the following will help to stop? Hemophilia A. So factor 8 deficiency is there. Replace the factor 8 deficiency. So give factor 8. Straightforward question here. When do we call it as a massive transfusion? By definition, if you're given more than 10 units of PRBC over 24 hours, another is 4 units over an hour's time if you are given, then also you call it as a massive transfusion. Most common complication is hypocalcemia. 35 years old woman with a history of epilepsy on carbamazepine, new onset lumbar pain. No fever or weight loss, and neurological examination is unremarkable. Which of the following statement is most appropriate? This would be due to carbamazepine-induced osteomalacia and should be investigated further. Or it is radiculopathy signs are necessary to confirm an spinal cause of pain. No, that is not there. Sarcoidosis must be ruled out as in primary cause. Doesn't make sense here. Carbamazepine doesn't cause any musculoskeletal complications. Not true. I'll be discussing why. Immediate MRI spine is required to rule out malignancy. No, we are not suspecting any malignancy in this individual. So what might have happened? Anyone that, especially the women who are on an carbamazepine, one of the side effect of or what it does is carbamazepine is an cytochrome P450 enzyme inducer. It is okay. It is a cytochrome P450 enzyme inducer. It is. So what it can do? It can increase the metabolism of vitamin D. So what will it result in? It will result in decreased absorption of calcium. Decreased absorption of calcium can result into osteomalacia. So osteomalacia can cause fractures. So the right statement here is this might be due to an carbamazepine induced osteomalacia should be investigated further. So anyone who is on carbamazepine presents with a fracture, suspect or you're suspecting a fracture in the individual, suspect it might be because of osteomalacia. Check for vitamin D levels, check for calcium levels in these individuals. So remember what will happen? Sorry. Remember what will happen in this individual. Because the individual is taking carbamazepine, it is an cytochrome P50 inducer. There will be increased metabolism of vitamin D, invariably, which will result in decreased levels of vitamin D because it is getting metabolized fast. This will cause decreased absorption of calcium, resulting in low calcium levels. This low calcium levels will result in osteomalacia. Okay, you need to be thinking in this manner. A 45 years old receiving a blood transfusion, after 1 hour, she develops fever, itching, prompting the transfusion to be stopped immediately. The temperature is 38.2 degrees Celsius. Rest of the parameters are normal. What is the next step? What are you thinking in this individual? They are asking. The next step is to restart the transfusion at a slower rate. So what are we suspecting in this individual? We are suspecting in this individual to be a non-hemolytic, febrile non-hemolytic transfusion reaction. So this is a febrile non-hemolytic transfusion reaction because all the parameters are unstable. It cannot be an extravascular because it has presented immediately. Febrile because there is a temperature which is present here. So keeping all this in mind, it is most likely an febrile non-hemolytic transfusion reaction. So restart the transfusion at a slower rate. There might be another thing also which might be causing here. It might be a mild allergic reaction also. Though fever might not be explained by the mild allergic reaction, but the patient is having an itching here. Okay, so mild allergic reaction sometimes can have fever also in this individual. In this, if it is a mild allergic reaction, what we'll do? Once we give an antihistamine and the symptoms have subsided, then we can restart the transfusion at a slower rate. IV hydrocortisone is not preferred or is not given routinely in mild allergic reactions. Send the unit for the blood loss for investigations is not required in mild reactions, what we have discussed previously, or allergic reactions. Perform cross matching again before resuming a transfusion. No, this is not an ABO incompatibility. Administer an IV adrenaline will be required in anaphylaxis. Vital parameters are stable to call it as an anaphylaxis. So that ends the class here. Anyone has any doubts? You can ask me now.